Welcome, everybody. It's 12 noon. We're going to go ahead and start the CMDA monthly meeting for August 3rd. We have a great agenda planned for today, and we normally would start with announcements from CHCA and CDPHE. And Jenny, if you're on the phone, go ahead and please unmute yourself and say hello, but I believe Jenny might be on vacation this week. And so if we would like to, we can go ahead and start with Chad Fear with CDPHE if he's on. I don't see that Chad is on yet either.
I just admitted him from the waiting room.
Oh, thank you.
So it might take him just a minute to connect.
Sure. All right. All right. Or if you'd like to, we could start with Dr. Eber. I don't know if you're ready, Leslie.
Sure, whatever you like.
Okay. Hi, Chad.
Hello.
Hi, thanks for joining us today.
You
I'm going
bet.
to put you on the spot and make you go first. Are you up for it?
Oh, you bet.
Thanks for joining us.
All right. I don't have a whole lot for you today. I did want to talk a little bit about some of the immediate jeopardy situations that we're seeing. Just kind of put that out there. Try to talk to every group that we have discussions with, just to keep everybody apprised to kind of what's going on. We've continued to have immediate jeopardy situations with facility acquired avoidable stage 4 pressure wounds. What else did we have? We have had immediate jeopardy with abuse. This was a sexual abuse. Significant medication errors. And then we've started seeing some immediate jeopardy situations and having more immediate jeopardy conversations about F880, which is infection prevention. So we're seeing patterns of issues with quarantining, isolation, sanitary dining, screening. Screening has, we've had some issues with that, housekeeping, PPE use, face covering, but really kind of one of the things that moves that from a discussion to determination of immediate jeopardy is looking at the monitoring that's going on. The facility monitoring its infection prevention practices, and then pulling all of that together, whether it be through the quality assurance process, or a more regular review if that's what's needed to make changes once concerns have been identified. Oftentimes then we'll see F867, which is the quality assurance tag, is also written. And I think for medical directors being a part of that review process and in helping facilities figure out how to, well, first of all, how to keep up with some of the changing revisions at this point, I guess I should say, to the mitigation guidance, to the practices that are expected with, the different things that are happening with the increase in the Delta variant and the response that we have to that. And just kind of looking at that whole picture with QA and monitoring and having that oversight and, identifying, I think, those situations which ultimately, fall in the COVID fatigue, or the realm of COVID fatigue. I think folks are tired. We fall back into some bad habits. We do see some non-COVID related infections have been present in a number of facilities, particularly norovirus and the strep A kinds of things.
Chad, may I ask?
Yes.
You mentioned the facility mitigation guidance. I know that the newest changes just came out July 23rd. Will the surveyors start to survey to that immediately, or when is the start date for the newest changes?
And so, kind of along with anything, the more time that it's going to take a facility to roll out its plan to address certain things, like, say, for instance, the daily testing per shift. We held off on that until we could be sure that supplies were at facilities so that they could do the rapid tests and that kind of thing. You know, a lot of it, I think, is just a change of practices. So there's a good part of it that we'll be looking at, you know, needing to be a part of the plan. Other parts of that, you know, there'll be some time to put plans into place. So it really kind of depends on the particular issue, and we hope to have those conversations with facilities, with facility leadership, and to really just, you know, take a common sense approach to, you know, to its rollout, to its application, and to you know, those things that we would want to see in terms of the monitoring, to make sure that we've addressed it correctly and we're achieving its intended results. One thing that has kind of reared its head have been some concerns over Legionella and the presence of Legionella concerns in a couple facilities and the presence in at least one facility. But I think it brings to light that, you know, we've had a number of changes in leadership, in administration, in you know, typically it's the maintenance director that's responsible for, you know, implementing the plan. And with all of these changes, wanting to make sure that you know, that the monitoring is going on, that the plan is in place, and the monitoring to validate the effectiveness of the plan is something that's happening. So we'll be talking to facilities more and more about that, but we definitely want to put that on everybody's radar, because it's you know, it's certainly one of those things that is you know, quite endangering if we end up you know, having those actual cases develop. So just kind of throw that out there.
Well, thank you, Chad. Thanks for committing to talking to all of our facilities. We definitely appreciate you talking with us today, and appreciate you being here to keep that dialogue going. I'd like to, thank you. I'd like to move on to our next speaker, Dr. Leslie Eber, who's going to give us a presentation on discussing COVID-19 vaccine and education. Thank you.
Thank you very much. Hold on a second here, and I will try to be quick. I'm trying to do this in 5.5 minutes. We'll see if it happens. Hold on. So I thought we'd do some quick tips on COVID-19 vaccine education, kind of what to say now. People are kind of exhausted about hearing about this, but it's obviously still important. Just some basic tips when you're talking to folks. Make sure that the person talking to staff is someone that the staff trusts. I like to share a COVID-19 update and fold in the vaccine education, kind of sneaking in the broccoli into somebody's, you know, brownies. Always be honest and transparent, and do the education at the nurse's station. Come to where folks are. This way you don't have a big crowd. Of course, never shame or judge. It is not a pathway to vaccination. It's not a pathway to trust or cooperation or collaboration. Remember, we want to promote vaccine confidence instead of addressing vaccine hesitancy. The framing of this conversation is important. Okay. It's often nice to start with these elements. Updating on the Delta variant. We are not done yet. It's very clear, but we have better tools now. I love this quote from Catherine O'Neill. The Delta variant is not last year's COVID-19 virus. That is also very clear. It's become incredibly apparent to healthcare workers that we are dealing with a very different beast. It's more infectious, more dangerous, and more deadly. And these are things that we want our staff to know. It will help frame the conversation about vaccination, and we want to be very clear about this. And then give information about your facility and the community about where you're all standing right then and there. You want to make this information relevant, talk about your positivity rate. These things will be really helpful as well to make it more compelling. Some current facts about people who aren't vaccinated. Who are these folks? What are they thinking? Just had a New England Journal Medicine study just published a couple of days ago, July 29th, from Anthem. I thought it was very interesting. They said it's very surprising that the lack of confidence in vaccine safety was still cited as the most common single factor that people are concerned about in terms of vaccine hesitancy. I thought we had thread that needle, but clearly we haven't. Remember, fear can be multifactorial: mistrust, fear of needles, concerns about side effects, and sometimes fear of uncertainty can be more frightening than COVID-19 infection itself. Also, fear of changing your mind. You may be incredibly embarrassed to change your mind. Sometimes that is the biggest obstacle. We heard yesterday from NACA, who is the National CNA organization for post-acute and long-term care. They said that that's what they're hearing, that people are kind of embarrassed and don't know how to change their mind. Maybe they don't want to think that their choices weren't consistent or admit that they were wrong. A sense of self and behavior changes are really difficult. Some solutions, you can connect this with other past choices and behaviors and their values: wearing your seatbelt, covering a wound, washing your hands, quitting smoking. These are things we can all agree on. Okay, hold on. Information that people want to know now, and this is certainly not complete because I'm doing it really fast, is getting the vaccine still worth it? Remember, we want to let people know the vaccine was created to prevent severe disease, hospitalization, need for a ventilator, and death. All the vaccines still do this. Even if we have breakthrough cases, it's a win to get the vaccine. And we need to make sure that people are still aware and framing that conversation in that way. So what about breakthrough cases? Everybody is talking about breakthrough cases. It's the topic du jour. Breakthrough cases, we want to let people know, are expected. We never thought that the vaccine was 100% effective, and indeed it's not. But doesn't mean that the vaccine has failed us. Even with breakthrough cases, they're usually mild and really not very many hospitalizations, ventilator use, or deaths. Right now, I only use 2 statistics because the people who were really interested in statistics have already been vaccinated, but I try to use these 2. The US now, 95 to 99% of the hospitalized patients for COVID-19 are not fully vaccinated, and over 99, sometimes verging on 0% of the people who are dying right now in the United States from COVID-19 are not fully vaccinated. You want to be in this, in the other group that's not in the 99% group that's in the hospital or dies of COVID-19. Of course, we want to connect with people. We want to talk about personal values. They have a passion for taking care of people ethically. We, had an oath that we would help people stay healthy. And that's part of our job. And connecting with that meaningful work can be really important. Protecting your own family, your coworkers, and then use your personal stories. That really resonates with people. Then it's a conversation, and sometimes it's a page turner. Okay, and the last one, Dr. Pellet asked me to share this with you. We just want to let people know that the FDA has now changed their status for their EUA for post-exposure prophylaxis. Monoclonal antibodies are now authorized to prevent COVID-19, new indications for people who are not fully vaccinated or not expected to mount an adequate response to the vaccination and have close contact with an exposure or at high risk of exposure because of COVID-19 and other individuals in the same institutional setting, for example, nursing homes. And so this is really great for our patient population. And I just want to say, I was going to ask Dr. Pollitt to send out this slide deck, and the rest of the slides are the most up-to-date data on side effects and things that people are concerned about. I'll just show you some of them quickly that we talk about: myocarditis, Guillain-Barré, pregnancy, and sterility. So I just wanted to let you know that this information is here for you guys, and thank you.
Thank you, Leslie. This looks like a tremendous slide deck. I'll be very glad to share it to all the CMDA members. If there are questions, please go ahead and put them in the chat box. Perhaps we can come back to them at the end of the presentation. I would like to give some time now to our other CDPHE team from the Acute Response Unit. We have Brynn, Berger, Dr. Diana Tapay, and April Burdorf with us here today. Thank you guys for being here.
Thank you for having us. So I'm just going to get some slides up to share with y'all.
Thank you.
All right. Whoops. There we go. Okay, so we came to talk about the Delta variant again today to give you guys more of an update. So since we were here last month, Delta variant has taken over. So it's currently accounting for more than 80% of sequenced infections in the United States. As we discussed last month, it does have increased transmissibility compared to Alpha and the wild type strains. And what that's resulting is we're seeing when there are outbreaks, there are larger clusters. And the other thing that we're seeing in some recent outbreaks involving Delta variant is that the CT values on those tests in vaccinated and unvaccinated people who are becoming infected are similar. So that's concerning that the vaccinated people may have a similar transmissibility compared to unvaccinated people, which is not what we saw with the Alpha variant last year and earlier this year. The most rapid case number increases that we're seeing across the country are in the areas of lowest vaccination coverage. Vaccinated individuals, even though we are seeing some vaccine breakthrough, still account for a very small amount of the transmission and the cases. So vaccine effectiveness against the Delta variant is always a hot topic. So these are some of the most recent numbers that we've been seeing. And the data that we're getting right now are coming out of England and Scotland, Canada, and Israel. So just looking at this table, I have it divided into confirmed infection, actual symptomatic disease, and then hospitalization or death. And then I have the numbers for each one of those categories comparing Alpha and Delta. So what you can see kind of across the board is that the vaccine effectiveness for Delta variant, particularly for confirmed infection and symptomatic disease, is lower than it was for Alpha. It's still very good, but it's lower than it was for Alpha. But the protection against hospitalization and death is still remaining very high. And then the biggest thing that we still don't have data to really show us exactly what's going on here is the numbers for Israel. You'll notice there is a huge drop in the vaccine effectiveness that they were seeing before Delta and after Delta, but they are seeing still just a very minimal drop in the vaccine effectiveness for hospitalization and death. So there's a couple of theories for why that drop is. It could be waning immunity. It could be a bunch of things, and they have studies going to look into that, but we don't have the answer for that yet. So the vaccine breakthrough cases, they are becoming more common, and that is expected because as more of the population is vaccinated, there are more vaccinated people to get sick. Most of those vaccine breakthrough cases are very mild. The vaccines are working as they should, as Dr. Eber just pointed out. They are preventing severe illness, hospitalization, and death, and that is the real point. And then, as I said, the vast majority of infections overall, hospitalizations, and deaths are still in unvaccinated individuals. And then just a quick note about monoclonal antibody therapy. Currently, the two products that are available are the Regencov, which is the casirivimab and imdevimab, and then sotrovimab is the other one. They're both authorized for treatment of mild to moderate COVID infections in individuals who are at high risk of progression to serious illness. And then just last week, the Regencov product also received its authorization to be used for post-exposure prophylaxis in certain individuals, as Dr. Eber just talked about. And then just to get you guys, so that this is my coming soon movie trailer announcement, we are working on an ECHO webinar that's a provider's guide to monoclonal antibody therapy for COVID-19. It will be offered on 3 dates that are going to be at the end of August and very beginning of September. We will have a HON that comes out that includes the information about that, as well as other monoclonal antibody information. And we're also going to publicize that through medical societies and facilities throughout the state of Colorado. So keep your eyes out for that so that you can attend that and learn more about monoclonal antibody therapy, how to offer it, et cetera, et cetera. And now I will turn it over to Brynn.
Thanks, Diana. So we did a similar presentation last month, but I'll just give a quick epi update. And so for those of you who weren't on last month, our first 2 cases of Delta variant were identified on May 5th in Mesa County from specimens collected in late April, and both of those cases were connected to a school outbreak at the time. As of last Friday, Colorado has identified 2,808 cases with Delta variant in 48 counties. Mesa County has had 31.7% of the state's Delta cases. In El Paso County, they've had 19.3% of all cases. Arapahoe County has had about 6% of all Delta cases, and Jefferson County has had 4%. And the other 44 counties have had smaller proportions of the statewide Delta count. Next slide, please. This slide shows our statewide variant Sentinel surveillance data. So on the y-axis, we have the percent of sequenced specimens, and then on the x-axis is the specimen collection week. And this is not all specimens sequenced in Colorado. These are specimens specifically for the purpose of variant surveillance. And you'll notice that from about March through May, the dark blue bar was the dominant variant there, that's Alpha B117. And then we see this kind of lighter teal bar up here in late April, and it has rapidly, and that's the Delta variant, and it has rapidly become the dominant variant in Colorado. When we last presented, Delta had been identified in about 75 to 80% of sequenced specimens, and now it's in the range of about 85 to 95%. And I don't have county-specific slides to show you, but in Mesa County, Delta variant has been identified in all but a few Sentinel specimens there. And in El Paso and the Denver metro area, Delta variant has been identified in most of the sequenced Sentinel specimens, but they're also seeing some Alpha variant and other lineages as well in those areas. Next slide, please. This slide shows counts of Delta cases over time by collection date. So at the top, we have Colorado Delta cases, excluding Mesa and El Paso counties. Then we have Mesa County in the middle and El Paso at the bottom. And so over time, we've seen Delta cases increasing in all areas. The Mesa has seen more of a plateau recently. What looks like a decrease there in the more recent weeks is probably just a data lag. It does take usually at least a couple of weeks for specimens to be sequenced. So that's likely not real decreases in Delta cases. Next slide, please. This slide shows some demographic and clinical characteristics of COVID-19 cases in general. So on the first two columns, it's COVID-19 cases excluding Mesa County statewide, and then Mesa County specifically. And then the two far right-hand columns are Delta cases. So Delta in Colorado excluding Mesa County, and Delta in Mesa County. And this is for the time period from early April through late July. And since our last update, we're seeing less of a difference between in Mesa County between COVID-19 cases in general and Delta cases. And that's likely due to the fact that most cases in Mesa are now Delta variant, even if we don't have sequencing results. So I've kind of grayed those two out, and we'll focus on the other two columns, looking at the rest of Colorado. So if we look at the mean and median age and the sex distribution of cases during this time period, there's not much difference between Delta cases and other COVID-19 cases. However, if we look at the row with hospitalizations, so looking at the column to the right, Delta, 9.6% of Delta cases in this time period have been hospitalized versus about 6% for COVID in general. So definitely a higher proportion of Delta cases being hospitalized. For deaths, for all COVID cases, excluding Mesa County, less than 1% of cases in this time period have died versus about 2% among Delta cases. So slightly higher, but these are fairly small numbers among the Delta cases. We haven't identified any reinfection cases with Delta variant, but we have identified multiple vaccine breakthroughs. So looking at COVID in general in Colorado, excluding Mesa, 6% of cases have been vaccine breakthrough. And we define that as laboratory confirmation of COVID at least 2 weeks following completion of a vaccine series. So 6% of cases during this time period have been vaccine breakthrough for COVID in general, but looking at Delta, it's about 15%. So we are seeing much higher proportions of vaccine breakthrough among Delta cases. Next slide, please. So at our last presentation, I shared some hospital admission and ventilator use data for Mesa County and El Paso counties. with some concerning trends in Mesa County at that time. So I'll just give a brief update here. When we last showed this slide, I mentioned that daily hospital admissions, and this is all admissions, not just COVID, in Mesa County had increased. At the same time, Delta cases were rapidly increasing. We were starting to see more of a plateau in admissions into July, and now we're seeing lower levels of admissions there in Mesa County. Next slide, please. Mesa County had also been experiencing a very large increase in adult and pediatric ventilator use. We have now peaked with that, and thankfully that is now declining, getting back to pre-peak levels in recent weeks. Next slide, please. In El Paso County, El Paso had an increase in daily hospital admissions in about May, prior to them really having much Delta identified. They did not see the same increase in admissions as their Delta case counts increased into June and July. And recently there's no apparent upward or downward trend. Next slide, please. And also at our last presentation, ventilator use in El Paso County had been elevated but plateauing, and that trend has continued and possibly with a decrease more recently. So that's somewhat comforting in the context of increased Delta and increased COVID case counts in general across the state. Next slide, please. And finally, I'll just give a quick outbreak update. So as of last Friday, we've had 61 outbreaks involving at least one Delta case, including 25 in residential care facilities. And 28 of these 61 outbreaks are currently active and ongoing. And so now I'll hand it over to April for an infection prevention update.
Thanks, Brynn. So I wanted to go over the changes that were released with the guidance update that came out on July 23rd. A couple of the just really quick updates that maybe don't need much discussion. We did remove the requirements for all of the facilities that were required to follow the enhanced infection prevention recommendations. So just as a reminder, that was in response to the Delta variant, and the majority of those facilities were on the western slope. Some interventions that were included in those enhanced precautions were incorporated into the guidance updates from on the 23rd. Email notifications went out to the facility administration on August 22nd for any of those facilities that were required to follow the enhanced precautions. And they were informed that they no longer had to follow those and that they could follow the updated mitigation guidance. We did add a requirement for unvaccinated healthcare personnel to wear eye protection if the county test positivity rates are greater than 10%. And we also added eye protection to the requirement for staff for facilities in an outbreak. Next slide, please. Now going over a couple things that we updated our language to better align with CMS. Some of these we had requirements before CMS had theirs, and we had not updated until this update. So we added in the requirement to stop indoor visitation when one or more positive cases identified. We previously allowed facilities to get the results of their first round of testing before they stopped the visitation. And we changed our language to align with CMS, and now it reads immediately rather than waiting for the first round of testing results. We also added the clarifying language that outbreak testing following the identification of one or more positive case must be initiated immediately. We had put language in there that we were allowing facilities 48 hours to get the samples to the lab for testing, but unfortunately that was being interpreted that facilities could wait 2 days, and we didn't really want them to wait, wanted them to take action once they identified positives. So again, that language was changed to align with CMS. Next slide, please. There was a section Diana and Alexis added for monoclonal antibody therapy. We don't need to go over that much, but just wanted to point out that that is in there. Now, we have had some questions from facilities as to whether this is a recommendation or a requirement. And just to point out that really the requirement is that they need to notify the physician for that resident that they have been tested, that they have tested positive for COVID, to allow the physician to evaluate whether or not monoclonal antibody therapy would be appropriate for this person. Next slide. Laboratory-based testing. We added the clarification that facilities should use a CDPHE contracted lab for their lab-based PCR testing, or they needed to ensure that whole genome sequencing of those specimens could be performed. So if they use a non-CDPHE contracted lab, we just need to have communication with them. And Jessica on the strike team has been reaching out to facilities, and they can email the strike team email address if they'd like to, just to let us know which lab that they're using, just so that we can make sure that they're able to do whole genome sequencing, or that we have a processes set up to get those transferred over to CDPHE lab. So that's a rationale for adding that. Confirmation specimen should be sent for lab-based PCR testing for all positive rapid tests. So this should be a second specimen that's collected at the same time that positive rapid test results. Next slide, please. Rapid point of care testing was added, and that can be either rapid molecular or rapid antigen testing for unvaccinated staff and those residents who have left the building over in the past 14 days. And we do define that as somebody who leaves overnight. So we're not including people that go out to lunch, or dialysis patients that would never get out of this testing cycle. Prior to the start of the shift, for staff members, if possible. Otherwise, if it's a large facility and that's just not able to be operationalized, then they should prioritize who they test first, with direct caregivers trying to get those test results back before they start interacting with residents. So it is okay for them to go into the facility, and it is okay for them to start report and some of those sorts of things, but we wouldn't want them to be starting resident care activities without those test results back. Positive healthcare personnel should be excluded from work and informed to isolate at home until those confirmation test results come back. A second sample should be collected immediately and sent to CDPHE or the state contracted lab for confirmation and sequencing if possible. There are a couple of the rapid testing options that we have been sending out are both molecular and antigen based. The two that we've been sending out to facilities through our lab are either the Q test or Binex. They can use the supplies from CDPHE, or they can use point of care antigen tests that they received from HHS. That's just fine. They can also use any sort of existing supplies that they may have, or some that they choose to purchase on their own. So there's a few different options for rapid point of care testing. Next slide, please. Surveillance testing. So this table was added to try to help make it a little bit clearer what needs to happen for routine surveillance testing. So staff that are unvaccinated need to test with a rapid test every day before they start work, and complete once weekly PCR testing if they're in a county with less than 10% 2-week test positivity. If there's a greater than 10% 2-week test positivity, then that increases to twice weekly PCR testing, which is similar to what we were doing before, just adding the rapid testing. Next slide, please. Residents that are unvaccinated who have left the facility, same thing. if they're in a facility with less than 10% 2-week test positivity, they would have a rapid test for 14 days from the date that they returned back to the facility. And they should also complete PCR testing for those 2 weeks. Next slide, please. Fully vaccinated and staff and residents are exempt from routine surveillance testing unless they have had a close contact. And we'll talk about that in a minute. Next slide, please. We also added a section for ancillary non-medical services, which is defined in the guidance as those services provided by individuals such as hairstylists, barbers, cosmetologists, and they are not employed by the facility, but they enter the building to provide services to residents. So these individuals must either participate in the facility surveillance testing or provide proof of lab-based PCR testing in accordance with the requirements. Next slide, please. The decision tree was updated to reflect some of the testing requirement changes. Next slide. This is just a reminder that crisis standards of care, which we have used as guidelines for how the medical community can allocate scarce resources during an event such as the pandemic. On June 30th, Dr. France deactivated the last remaining crisis standards of care for PPE in Colorado. And so what this means for facilities is that they need to make sure that they're following conventional strategies. And going back to pre-pandemic times for PPE use, if facilities need to follow crisis standards of care because for example, maybe they have an outbreak and they've increased their use of PPE, they do need to contact CDPHE by completing the activation request form on the following website prior to implementation. So basically, they would need to complete that form, and that is trying to get people connected so that we can try to get supplies to the facility. Next slide, please. So here is a sneak peek, as Diana said, for the movie trailer. We are in the middle of updating guidance once again. I know we just released updated guidance, but in response to CDC updating their masking guidance, we have created some changes to the guidance. It is currently at the governor's office. I am hoping that we might see that come out today. And a couple of those proposed changes that I suspect will be in there is adding the requirement for universal mask use for everyone who comes into the facility. That will then realign CDPHE guidance back with CDC's guidance. Adding testing requirement for fully vaccinated healthcare personnel and residents who've had a close contact. So for example, a household member that has tested positive, adding clarifying language regarding quarantine for individuals who have had close contact, and adding guidance when there's discordant results between the point of care testing and lab-based PCR testing. So hopefully we'll see that come out very soon. If something happens, in the next few hours before the strike team, I'll give you all a heads up at the strike team meeting later. So I think that's all I have.
April, I have a quick question for you. It's Greg. Can you think of a situation where if you had discordant results that you wouldn't trust the PCR over the POC test?
The only thing that comes to mind is maybe if someone has symptoms. And I think most of what we're concerned about is facilities just repeating until they get a negative result and not taking the whole picture into account. So some of those that might slip through the cracks, like someone who has symptoms and maybe they've had a close contact. But no, I think for the majority of those, we would definitely act on the lab-based PCR result over the rapid result.
Thanks.
Thanks for that late-breaking information. I hope that we'll get some more updates in the next few hours or by tomorrow. Thank you so much, April. Thanks, Dr. Tapay and Brynn. We appreciate all those recent updates and details. If people have further questions, please go ahead and put them in the chat box or let me know and we can forward them to our CDPHE partners. So thank you so
Did
much.
see
At
one
this-
question in
Yeah,
the
go
chat
ahead.
about the
Yes.
UK vaccination numbers, that yes, they are using AstraZeneca there, but they are also using Pfizer. And all the numbers I gave you in that table were Pfizer specific for all the countries.
Perfect. Thanks for clarifying that. I think we get so focused on the vaccines we're using right here, we forget about checking on the other ones. Thank you for that context. Our next speaker is Mr. Alan Horowitz, and I'm looking forward to his perspectives on the Life Care Center of Kirkland case and COVID-19 pandemic that started right here in the United States in our nursing homes. And I'll go ahead and let you introduce yourself, Alan. Thank you.
Thank you. It's a privilege to be speaking before you folks. I appreciate what you do. You guys and gals are the real heroes. So my background is healthcare. I'm a nurse and a respiratory therapist. And for the last 31 years, I've been practicing health law. My focus is on long-term care. I used to represent CMS. Now, for the last 9 years, I represent providers. The good news and the bad news is the bad news is this is an hour presentation. The good news is we're going to get through it in the next 25 to 30 minutes. And so forgive me if I talk fast in the limited amount of time. But I wanted to talk about something that's near and dear to my heart, and that's when bad things happen to good providers. And I used two cases, one of which was a case that I represented CMS in when I used to litigate cases on behalf of CMS. And the other is the Life Care Center of Kirkland case, which is the index facility in the United States for the first outbreak of COVID, because I think that the respective medical directors in those two facilities really highlight what an absolutely critical role a medical director can play in not just the survey, but in the outcome of the facility and resident care. So with that, I'll just dive right into the presentation. I have no conflicts whatsoever to disclose. And my hope is that in the next 25 minutes or thereabouts, that we'll see some lessons learned from the first COVID case in the United States. Again, I'll just call it Life Care Center or Kirkland. It's the same facility. We're going to talk a little bit about your role as a medical director, both before, during, and after the survey, and how you can determine the adequacy of policies and procedures in your particular practice. And that is a requirement, a federal requirement of medical directors to be actively involved with policies and procedures, even if you do not sign off on them. But I would be remiss if I didn't at least mention a couple of legal actions and potential areas of liability for medical directors and attendings, as well as SNFs. There's DOJ or Department of Justice investigations, OIG, which is the HHS Office of the Inspector General, and typically they'll look at False Claims Act violations or allegations of such, Stark violations, anti-kickback violations, something known as the MFUCU. Every state has a Medicaid fraud control unit, and that's similar to what DOJ does, but it does that at a state level. And of course, where you'll have the most interaction with any regulatory entity will be surveys, particularly those surveys that lead to state and CMS enforcement actions. As we all know, there's negligence and wrongful death actions, and there are law firms that unfortunately make a living going after nursing homes for quote unquote nursing home negligence. Some of the most common allegations that we see in nursing home litigation are on this slide, and I highlighted the bottom bullet, infection control and testing, because that is clearly in the last year been on the rise. There are many, apart from CMS enforcement actions against facilities, and F880 is the infection control or IC, FTAG, we're seeing collateral civil litigation in that regard. Typically, they're wrongful death allegations. According to the OIG, OIG looked at the top 10 tags for the period of 2013 through 2019, and those are the top 10 tags. I suspect if OIG looked at the 10 tags right now, infection control would be at the top of the list. As everybody knows, up until recently, all of the surveys were infection control surveys. The survey teams are still doing infection control surveys. And even if it's an annual survey or complaint investigation, they're looking, as they should be, at facilities, infection control and prevention protocols, and whether or not there are any outbreaks. In terms of the regulatory framework, I'm often asked, well, how can CMS do this? Can CMS do this? Well, the answer is, in terms of the enforcement actions, CMS is authorized to impose a litany of enforcement actions by the Social Security Act, and then the implementing regulations, which are found at 42 CFR, Code of Federal Regulations, Part 8. 483. The issue that I have with surveyors and actually with CMS for 20 years now, even when I represented CMS, is to remind CMS that the State Operations Manual, or SOM, is not law. Years ago, about 10 years ago, the National Director of Long-Term Care for CMS, Thomas Hamilton, issued a directive to all state survey agency directors that surveyors may not cite a deficiency based solely on the SOM. I frequently have cases, often where the CMP, or civil money penalty, is in excess of $1 million, and the basis for the alleged deficiency is a violation of the SOM. That's not legally sufficient. It has to be a violation of a regulation. And again, that's something that for 20 years I've been arguing for, and even CMS Central Office acknowledges that, but oftentimes surveyors mistake. Recently, in a case that I tried in Washington, D.C., when I was cross-examining the team leader, she said, well, the SOM are the regulations I go by. And that was her sworn testimony. Again, the SOM is simply sub-regulatory guidance. In terms of the enforcement actions that CMS can impose, it's everything from a CMP per instance or per day. The amount per day can be upwards of $20,000, a DPNA or denial payment for new admissions, directed in-service, directed plan of correction, state monitoring, loss of the nurse aid training competency program. CMS with the state can impose a temporary manager. And of course, CMS is the ultimate weapon, which is terminating a facility from the Medicare program. Termination from Medicaid is derivative, and that will follow. Some of the remedies are discretionary, some are mandatory. So if a facility is out of compliance for 6 months, they will be terminated from Medicare program. This is a typical ad. Actually, this is pretty benign from one of the plaintiffs' firms. Our firm has sought injunctions against some of the more aggressive law firms that will cut and paste from 2567's statements of deficiencies that are more than 5 years old, have billboards on I-95, up and down I-95 on the East Coast, saying if you or a loved one been injured at, and then there's an arrow pointing to the next exit with the name of a nursing home. So I want to talk about 2 cases in my remaining time, because I think this really highlights the role of the medical director. This was actually one of my first cases when I represented CMS almost 20 years ago, and all of the facts were taken from the case. The only exception is I chose not to use the doctor's name, although this is the published opinion. You can find this online, and the judge pretty much, as you'll see, skewered the medical director who was the attending physician. So basically, there was a 93-year-old male who was fairly active until November 22nd. He was admitted to the hospital with a diagnosis of AFib, CHF, chronic renal failure, GI bleed, electrolyte imbalance, blindness, and dementia. Nonetheless, this gentleman walked with a cane and was, according to hospital records, fairly independent in his ADLs. He was admitted to the SNF, quote unquote, at least temporarily for gait strengthening, since he walked to the bus every day. Once he was at the SNF, he finished the course of PT, and he was determined to be independent in his ADLs. His fall risk initially was 13. Again, any number above 10 is high. He had somewhat of an unsteady gait, and he had a history of osteoarthritis. The meds that he were on were Ativan, Lasix, and Coumadin, above others, but I listed those for a particular reason. We'll see why. So here's a chronology, a brief chronology of what happened. His first fall, and again, this is just going back, he was admitted on November 22nd. He's fine until December 17th when he's found on the floor. March the 3rd, he's found on the floor. The fall risk assessment is increased from 13 to 17. Obviously, he's at more of a risk of falls. He falls again the next day, actually he fell twice on May 4th and had a laceration under his right eye. He fell again on May 7th with small bleeding skin tear documented on his buttocks. And at that point, he was noted to have altered mental status. And there were obvious changes. On the 12th, he fell again. He had another head injury. Then on the 20th, he fell, and on the 21st, he fell with a laceration on his forehead. On the 23rd, the nurse's notes indicated that he was agitated, yelling, and banging on the wall with his cane. And some of the information that I'll share with you that's not on the slide, he would take feces and put feces on the wall. This was a gentleman who was alert and oriented ×3 on admission in November, and now he's clearly has an altered mental status. 6 falls in 18 days in May. So what does the facility do? Well, actually, they did nothing. And the quotes here are from the judge's published opinion. The case, as you can see, is Autumn Care of Norfolk. If anybody wants to look it up on the DNB website, the judge determined that the falls committee had no coherent approach to preventing falls. The administrative law judge, in this case was decided by Judge Hughes, she commented that the attending physician, who again was the medical director, had little if any involvement in assessing resident 1. Dr. X distanced himself from any involvement in resident 1's care. There was no evidence Dr. X saw or evaluated the resident after falls until he was in a hospital. It was the first time that the—
Alan?
Yes.
Alan, this is Singh. Your microphone or something has changed. It sounds like you're maybe the mic's covered up or it's echoing or something.
Okay, is that any better now?
No, I'm not sure what happened. It just changed while you were talking.
I don't know. I haven't done anything differently.
Okay.
Can you hear me? Am I audible?
Oh, this is a little better. Yes, this is
Okay.
much louder.
Okay, maybe there's something in the air.
Thank you very much.
No, thank you for pointing that out. Please let me know if that's a problem again. The ALJ continued in her decision to indicate that, and this is pretty damning statement in a published opinion from a federal judge, Dr. X's involvement, and of course she used his real name, Dr. X's involvement with resident 1's care seems careless and haphazard. He had a note in the hospital that there was no history of shortness of breath or a cough, yet one of the other physicians at the hospital indicated his chief complaint was shortness of breath, coughing of phlegm. There are numerous other medical consistencies. For example, the hospital records, he described the resident as frail and cachectic, while the doctor, who was the medical director, documented he was well developed and well nourished. And probably most startling, in the death summary for resident 1, the physician indicated, the medical director, who was the attending at the SNF, indicated he was an African American male. He was not. In terms of the orders, he was ordered, and here's an exact quote, 0.5 milligrams of Ativan, PRN, at bedtime for insomnia and agitation. The nurses interpreted that order to mean, well, he'll get a 0.5 milligram of Ativan at bedtime, but also anytime he's agitated. So this gentleman who had 6 falls in 18 days was getting Ativan throughout the day, and he continued to fall, which is no surprise. The Coumadin was not DC'd even after multiple falls, and the physician on cross-exam couldn't explain why he didn't even consider that. And again, just by way of quick reminder, this gentleman died 2 days after being admitted to the hospital because he sustained an acute subdural hematoma. The RNs didn't perform neuro assessments after a fall. They didn't notify the physician of the change in altered mental status after the fall. One of the most troubling nurses' notes was at 1:30 a.m. the last day that this gentleman was in the facility. The nurse indicated he was lethargic, would not open his eyes, rails and bronchi, incontinent bowel and bladder. His temp was 103.7, involuntary jerky movements in his bilateral hands on his right leg. His pulse was elevated to 100 and his respiratory rate was 28. What does the nurse do instead of calling the physician? She indicates we'll continue to monitor. She doesn't call, and she gave a Tylenol suppository and a sponge bath. Actually, she also tried to insert a honey flavored substance into the resident's mouth, who was unresponsive, and I'll never know why, and she couldn't explain why either at cross-exam. Again, this gentleman hours later, he sent to the ER. Diagnosis is confirmed on CT scan as an acute subdural hematoma. It's inoperable, and he passes away 2 days later. Some of the take-home points here were surely that the nursing staff needed to carefully monitor the neuro status, particularly post-fall with head trauma. Ambiguous orders, such as the order for Ativan for insomnia and agitation, should have been clarified. The attending physician should always be made aware of significant changes in condition. That's just good medicine, good nursing, and also a federal requirement. And there should have been adequate policies and procedures so that these things wouldn't have fallen through the cracks. This is an example of a systems problem. It's not just the physician, it was the nurses around the clock. It was the false committee. The QAPI program was ineffective. The QAA committee wasn't even meeting to address some of the issues in this period of time. So that is very quickly a worst case scenario. One of the worst cases I saw, I'm not sure why the provider appealed it. Needless to say, they lost. So by stark contrast, I want to shift over to the Life Care Center Kirkland case, where I've said this publicly and I've written this. It's my opinion, and that of many other people, that CMS is absolutely scapegoating Life Care Center Kirkland. So let's take a look at the facts very quickly. So in January and February of last year, a number of residents presented with flu-like symptoms, which is not atypical, as you know, in the Northwest and in the winter months. Nothing particular was thought of. There were no red flags at that time until February 26th, when the infection control nurse thought, okay, there's something going on here. So she called the county Department of Health and the State Department of Health. At that point, multiple residents were experiencing respiratory symptoms. There was no response from either the county or the state. So the infection control nurse at Kirkland called again the next day, and they did respond. On the 28th of February, the first case of COVID-19 was confirmed. I should mention that the facility had asked CDC for permission to test for COVID-19, and they were not allowed to do that initially. On February 29th, the first death in a nursing home in the United States was attributed to COVID-19. That was actually the second death in the country, and that's in February 29th. So let's just fast forward to March. On March the 11th, the World Health Organization declared a pandemic. On the 13th, President Trump declared a public health emergency. Also on the 13th, CMS recommended restricting all visitors to SNFs except for compassionate care, meaning a visitor who wanted to visit a dying relative or someone on hospice who was on their way out. So one of the things that I've noted, and I've been involved with the Kirkland case, I don't represent Kirkland. I've helped with the briefing, and I've done an amicus filing on behalf of AMDA, which I'll talk about if we have time, are the inconsistencies. So during this period, and unfortunately, long after this period, there was confusing and inconsistent advice from both federal and state officials.
This is Singh again. Did you do anything differently? Because the sound just suddenly switched again.
I didn't know.
Kind of hollow, and yeah, sorry about that.
No, thank you. And how about now? Any better?
Not really. I don't know if any position changed or anything. It is almost 1, and I just want to at least let the audience know that you've been very gracious and happy to send out your slides to everyone. And so I will do that along with the handouts that you're going to be mentioning too. And if anyone has questions, of course, forward them, and I'll make sure that Mr. Horowitz gets back to you. But why don't you go ahead and try to speak again? And I'm not sure, last time you tried again and it worked.
Yeah, is this any better?
Not really. I don't know what happened.
Yeah, I apologize for this.
Yeah, maybe you just speak really loud and we'll try to catch you.
Okay. A little closer.
Yep, you came back in.
Oh,
Thank
okay.
you so much. Yep, you're good.
Okay, so my point is there was inconsistent advice. For example, Nancy Pelosi, senator from California, after Kirkland already reported a case, was saying, come to Chinatown in San Francisco. Mayor de Blasio was saying, come to residents in New York. Dr. Fauci was saying masks aren't necessary initially. The World Health Organization said no human-to-human transmission. Then President Trump was downplaying the extent of this. the point is, we didn't know what we didn't know about the virulence and the transmissibility of COVID-19. And the recommendations, not regulations, recommendations from CMS and CDC were evolving. Much of the transmission was from somebody in the community who was bringing it into a nursing facility who may have been initially asymptomatic or pre-symptomatic, which really changed the calculus here. Nonetheless, Life Care Center Kirkland was held accountable. The surveyor cited multiple immediate jeopardy deficiencies, including the medical director tag, and the medical director tag on statement of deficiencies was really kind of bizarre, and I'm surprised CMS let that fall through the cracks. Two of the reasons they cited the medical director F tag was because the medical director, Dr. Kumar, wasn't at the facility 24/7. And as everybody on this call knows, there's no federal or state requirement that requires a medical director or any healthcare practitioner to be in a facility 24/7. The other basis for the medical director tag was that the medical director did not attend a QAA meeting a year earlier, which had nothing to do with infection control, and COVID-19 wasn't even heard of a year earlier. Nonetheless, that was part of the basis for the medical director's alleged deficiency. CMS imposed a $611,000 and changed CMP. The state of Washington imposed a ban or stop placement order on admissions. So Kirkland appealed both the state and the federal action. I'm happy to tell you that Kirkland prevailed at the state level, and in the decision from the state ALJ, the quote from the decision is that the department, meaning the Washington Department of Health, abused its discretion in imposing the stop placement on admissions action. Washington appealed that adverse decision to the state, and the decision was upheld. So the matter is finalized at Washington State, and as the ALJ indicated in his opinion, which I forwarded a copy to Dr. Pallett for your edification, if you ever want to see it, the ALJ found that Kirkland did everything that they could have and should have done under the circumstances. The federal appeal went before the federal ALJ this past April, and the administrative law judge said he expects to have a decision next month by mid-September. A couple of very quick facts, because I know I'm just over 1 o'clock. Prior to the March 2020 survey, and I think this is important, Life Care Center Kirkland was a 5-star facility. And about a month prior to the February outbreak, they voluntarily disclosed that they thought they had a resident with TB. They made the disclosure. Surveyors came into the facility. It turned out the resident did not have tuberculosis. And in fact, the survey team complimented Life Care Center on its infection prevention and control protocols and policies. And this was, so let me repeat that. A month before they got dinged on a survey, they were complimented for their infection control, prevention and control policies and procedures. Seems a little bit inconsistent. What really helped the facility was documentation. Dr. Kumar, their medical director, as well as the infection control nurse and physician assistant, all ended up testing positive. Dr. Kumar, the medical director, was being effective from his home, from his sickbed. He was giving verbal orders, telephone verbal orders as appropriate, and he was actively engaged. Again, this seems to me and many others that Kirkland was being held to standards that just simply didn't exist in February of 2020. Just very quickly, the role of a medical director, and this is just a partial list. One of the things that CMS is looking at more and more in terms of the surveys is whether or not the medical director has been involved with policies and procedures, whether the medical director or his or her designee is actively involved with the QAA committee, which is subsumed in the QAPI program. Probably the two things right out of the regulation that surveyors will look for, and there's language in the SOM that gives surveyors much guidance about this, is that the medical director is responsible for the implementation of resident care policies and the coordination of medical care in the facility. And that's pretty, obviously, that's pretty broad and wide ranging, and just about everything within a facility falls under the ambit of medical director's responsibilities. So that's a lot of responsibilities. Again, just to summarize, autumn care, the first case we looked at, the judge indicated in May 2000, resident one suffered a series of falls, one or more which likely caused or exacerbated an acute subdural hematoma, which led to his death. That, coupled with the statements against the medical director, are a treasure trove for the plaintiffs' law firms that go after nursing homes. But by stark contrast, Life Care Center Kirkland, the ALJ, the state ALJ, indicated there's no clear evidence of what the facility could or should have done differently in this regard. The attorney that represents Life Care Center Kirkland told me that initially there were some wrongful death actions, but when they saw the decision from the state ALJ, they're rethinking whether or not they want to go forward and they'd like to settle. Again, if you've got an adjudication from a court of competent jurisdiction at a state or federal level that says there's no clear evidence of what the facility could or should have done differently in this regard, it would be hard pressed for a plaintiff's attorney to argue before a jury that the facility should have done something different. It won't stop many of those firms from going forward with the cases, but that's powerful evidence. So again, Kirkland, because they had the documentation to illustrate and to demonstrate that they followed their own policies and procedures and that they were doing everything as well as they could have under the circumstances. One final comment from the state ALJ is that the department presented no evidence of what they may have done that would have changed the outcome for their patients. The department, meaning the Washington Department of Health, has not shown that their response in terms of their management of the crisis was inadequate. And the ALJ reversed the stop placement order, which is the same as the federal ban on admissions. I want to close by saying the medical director, your role as medical director comes into play before the during the survey and post-survey. Often in my cases, when I'm filing an appeal for a facility, the medical director is going to be both a fact witness and an expert witness. So again, there's hopefully a medical director's involvement with survey team will eliminate those deficiencies that do not have a factual or a legal basis. Oftentimes, having a medical director talk with the surveyors makes all the difference. Again, the surveyors aren't physicians. Oftentimes, they're not understanding a complex clinical situation, and with some elucidation from a medical director, that may make the difference between immediate jeopardy and no deficiency at all. So with that, and I've gone over my time, I just want to acknowledge the tremendous work that all of you do. Even before COVID-19, I think it takes a very special person to be a geriatrician, and likewise for the NPs and PAs that work in this area. But for all of you who are medical directors and attendings, again, I just want to tip my hat. You do a superb job. You don't get the credit you deserve. And unfortunately, in many states, not so much in Colorado, but in many states, particularly in the Southeast United States, which is Region 4, the survey process has become incredibly adversarial, where surveyors are antagonistic to medical directors. But I just want to thank you all. I know I've gone over my time. I apologize for that. If anybody has any questions, feel free to email me. My email address is on the cover slide. Thank you for your time and your attention. And again, thank you for all that you do.
Well, thank you, Alan. What a tremendous presentation and experiences that people have gone through. And don't apologize. I know that we have limited time. If anyone has any questions, please feel free to ask now or forward them to us, and we'll make sure you get them answered.
This question is directed to someone who knows about vaccines. Is there any talk about a booster vaccine?
Could I?
Yeah, I was going to say maybe Dr. Eber might give a response.
Sure. I know that there's been a lot of talk about boosters, and the ACIP had their meeting in July talking about boosters and the data that's currently available for immunocompromised patients. We are still waiting for the FDA and the CDC to give some guidance. Right now, with the emergency use authorization as it is, and no approval of any COVID-19 vaccine outright, the FDA would have to change the EUA to make it possible for us to give boosters to either immunocompromised patients or any other patients, maybe older patients with comorbidities like our patients. So we're kind of in a standstill. The ACIP presented really compelling data that for immunocompromised patients, that having a booster, a third shot, even of the same vaccine that you had the first 2 shots for the messenger RNA vaccines, that it's very, can be very helpful, and up to a third of patients mounted a response who really didn't have much prior. We can share that slide deck with you, but right now, I think we're just waiting for the CDC and the FDA to give us some guidance. I suspect, if I was a betting person, that we will need both boosters, both for immunocompromised patients and for our patients. I mean, that's my best guess, but we know that Israel's already giving boosters to immunocompromised patients and to older patients. In some circumstances, I think it will be needed and warranted.
Thank you for that response. I think that we'll keep our ears out for any further developments in that area.
Does anybody else have anything that they might want to add? Just for booster shots?
If not, we do thank you all for joining us here at CMDA for our monthly meeting. Our next meeting will be in October because September's meeting falls right near Labor Day. And we're happy to relay any questions back and forth from the speakers and send out the slides they've made available to us. So thank you all to all of our speakers today, and thank you all for joining us. Have a good day.